We can continue in the rest of the decap BTLS, but be advised that you need to know about lacerations, contusions, abrasions, hematomas, avulsions, and such. So think about that. I want you to just remember, when looking at these type of injuries, consider the mechanism injury, treat all the life threats, retain any dismembered or parts that are severed from your patient, keep them in a cool, sterile environment, minimize further injury to that dismembered body part, avoid contamination, and avoid freezing. When we deal with punctures or penetrations, treat the life threats again and try to immobilize the impaled object. This may be causing a tamponading effect on potential blood vessels or organs that, if were removed, would cause quite significant blood loss. When we look at our high pressure type wounds, think that there's some cavitational forces. Now, one of the other types of injuries that we should discuss is high pressure type injections. These are liquid or gas. This just causes a severe tearing and ripping or severing of the epidermal and into the dermal layers. If it's done into the face, it's pretty detrimental. It could really wipe open a lot of soft tissue. This high pressure injections, we're looking at nail guns, we're looking at paint sprayers, we're looking at pressure washers, those type of equipment. Again, so now just to recap, stabilize any impaled objects, trim around the object, maintain that there's no vibration or heat that's being displaced through the object into the patient, making sure that you're not extending the injury itself. If we come up with our arterial lacerations, we look at arterial spasm. The arteries tend to spasm shut for a while. Hopefully this decreases blood. Be careful that air also can enter the artery at that time. And a lot of times these arteries are in non-compressible sites, and this is why we're talking about them now. These are not the ones we put a tourniquet. These are in the areas of the neck. These are the areas under the armpits or somewhere in the groin area where they're not really, it is very hard to compress, takes a lot of time. Somebody has to be managing and holding that area at least 10 to 15 minutes, if not the entire trip, just managing that one area. All right, cross injuries. This leads to cell death. We know that we get cell death. We have leaking of the cell contents. We have leaking of its primary electrolytes and acidosis. So we have hyperkalemia and acidosis, as well as myoglobin and this protein loss. This can overwhelm the kidney, and it also can cause the myocardium to become very irritable. And you see people in arrhythmias. So rhabdomyolysis is another type of injury that damages because of excessive clot formation, excessive bleeding. We see this influx of hyperkalemia rushing towards the kidney. And this is our acute kidney injury. We talked about this previous classes. This is a pre-renal cause, or it could be pre/infrarenal, as hypotension and damage to the nephron itself causes damage to the kidney. Compartment syndrome. Compartment syndrome is where we mentioned the fascia. This is below the epidermis, below the dermis, below the subcutaneous layer, and we have this thin cellophane-like, as it's clear, covering over the muscle. And as it overlies this muscle, if bleeding from a blood vessel or bleeding from the muscle expands, it can expand because of the fascial lining. So this fascial lining will cause compression. It'll compress the muscle, it'll compress the blood vessels. This fibrous lining, again, is unexpandable, and underneath that area it contains blood vessels. Compression to that area will decrease blood vessels, supply of blood flow to those blood vessels. Then they'll complain of severe pain, paresthesia, paralysis, puffiness, pallor, and pulses. These are your 6 P's. Pain, edema, immobility, and increased pressure in that area. So they're looking at decreasing that by reducing the pressure. This can also be caused by bleeding into that space, or it could be due to circumferential burns, which we'll talk a little bit about later. Now, management of our crush syndrome. It usually occurs 4 hours since or post the event. So the person has been on the ground for 4 hours or been compressed for 4 hours. It's enough to cause cellular death, the release of cellular death toxins. Then we have the acute kidney injury, lethal cardiac arrhythmias. We need to give fluids so we can flush the kidneys, and we can think about administering bicarbonate. Let's go ahead and follow our local protocols, but that's what we're trying to do here. We have acute kidney injury. We need to get the kidneys flushed. And this hyperkalemia that's involved in there may require, and acidosis may require bicarbonate administration, plus or minus calcium. Now we have a lot more of these soft tissue type of injuries and soft tissue infections. I'm just going to kind of list them all. You're going to have to go look over them. There's superficial infection into the wound itself. This hasn't gone deeply and hasn't become a systemic. The lymph nodes are not necessarily involved. There isn't that red streaking. There's a lot of edema. There's not a lot of redness. It's not very hot to touch. It just looks inflamed and looks kind of weepy. And so that's that superficial infection. We know maybe it's probably some kind of staph. It needs to get cleaned out. We need to monitor that so it doesn't develop into a more systemic type infection. Other infections can happen to the hair follicles, more than a few follicles. It can then coalesce and become from a folliculitis to a furuncle, and more furuncles ends up into nodules. It can become an abscess, this larger cavity pus that fills up beneath this hair follicle. It becomes this fluctuant mass, and that's our carbuncle or abscess. Now, when we look at cellulitis, now we're looking at the skin being hot, red, irritated, swollen. It may be systemic. We have bacteria that now has entered the bloodstream and into the lymph nodes. And definitely, if they're immune compromised, this will definitely transfer itself quicker. Necrotizing cellulitis leads to tissue death and ecchymosis. Necrotizing fasciitis is where it affects the fascia. Clots obstruct, increase colonization of this type of polymicrobial infection, and it can progress rapidly and aggressively. Now, some of these other types of skin infections may look like some type of cellulitis, and I guess they're throwing it in there because we deal with these, and you may see these. One is called the herpes simplex virus, HSV 1 and 2. These are the ones that we can see around the facial area. They may start on the lips. They usually are regress back into the nerve endings, and then they tend to expose themselves and evolve and erupt during stressful times that the patient is experiencing. And this may cause this type of weeping sore around the lip or around the mouth area. Another type is shingles, or the herpes zoster virus, is part of the chicken pox or varicella virus. This is, again, anybody that's had the varicella virus that has had chicken pox, they can have a secondary type of infection. Again, this only happens to dermal distribution of half the dermal distribution. So I talked to you about dermatome distribution across the spinal column. As the spinal column comes down, we know that the cranial nerves or cervical vertebrae can innervate around the cervical area. We look at the thoracic vertebrae. Let's start back again. The cervical vertebrae around the cervical area, they extend down through the upper extremity. Then we look at the thorax. The thorax will take part of the upper extremity and then across the above the mid-mammary line. And then we look at having about the fourth thoracic line, about the nipple line, and the 12th all the way down at the top of the iliac crest. and it's during these distribution, this dermatomal distribution, that the shingles will occur and never crosses over from the right to left. Further, one's going to extremity injuries. These are infections to the nail bed, to the finger pad, and then into the palmar surface. Why don't we focus more on wound cleansing right now? Just read up on those. But the wound cleansing, we don't want to use anything that's abruptant or abrasive to normal and healthy cells. Alcohol, peroxide, benzene, betadine, they destroy cells. We look at warm saline or even warm water and soap. The head, as we clean, is highly vascular. In fact, the head, scalp, and nose and facial area are very vascular and tend to bleed a lot. So use a lot of compression into that area. When you start to wash and irrigate out those areas, they will tend to bleed again. As far as the face and ear areas, eyes, ears, nose, and throat, we try not to obstruct the ears, eyes, nose, and throat if we suspect that there's some kind of increased intracranial pressure based on mechanism of injury, based on patient presentation, based on whether or not we think that there is some cerebral edema going on. Right? Neck, again, is a non-compressible site. We're going to have to put some direct pressure. We may use the opposing arm to come across of the patient to help to compress that wound site.